Well, thank you very much. So it's a great pleasure to be here in Melbourne and to participate at this very interesting meeting, and I already want to congratulate the organizers to this extremely interesting program which covers a wide spectrum of areas related to seizure prediction and far beyond this. And I think it's really giving lots of topics here which are very much directed to the future. So my task is to go to the very basics and to start with basic epileptology, mostly for those who are not familiar with this from a clinical point of view, and I will try to go through this briefly in some aspects which may be relevant here. So epilepsy was considered a disease related to particular types of discharges of the brain already before the time that we had any EEG recordings available. And it was, in fact, Jackson who said that epilepsy is the name for occasional, sudden, excessive, rapid and local discharges of gray matter at a time when this could have been considered very speculative. But basically it has remained our definition of epilepsy since 1873. And what you read now in our nowadays definition of epilepsy is very similar. It's a transient occurrence of signs and symptoms due to abnormal, excessive, or synchronous neuronal activity in the brain. And if this happens repetitively, then we talk about epilepsy. This is the current definition of the International League Against Epilepsy. Epilepsy is a frequent disease, so about 1% of the population suffers from epilepsy. It depends on how you really calculate this, so if you make a cross-sectional approach, you may be at a range of 0.6%. If you look at the whole lifespan, you may be in the range of 3 to 4% of the population suffering from epilepsy. And you see why that is. So we have an increase incidence of epilepsy in the very early years and again in the late years. And due to this fact here, in fact, the prevalence of epilepsy is now increasing, so because it's really the highest range that we have in our populations in the Western countries at least. Well, if we talk about the phenomenology of epilepsy, everybody thinks of seizures, but epilepsy is more than seizures. So at least in focal epilepsies, you can have changes on the psychiatric side, like mood changes, prior to the occurrence of any seizures. Then you have the manifestation of certain seizure types, and later on you can have cognitive impairments during the course of at least focal epilepsy, and you have physical risk associated with epilepsy. So how does this semiology come about? So it depends on the region of the brain that is involved, what kind of semiology you will have. So if you, for example, have involvement of the frontal lobe, you will have these motor phenomena because the frontal lobe is involved in producing and controlling motor behavior. So you can have this very complex, we call hypermotor, the phenomena with some control mechanisms not working during the seizure period. If you have the seizure in an area where you have the primary motor cortex, it doesn't work, it worked very recently. If you have it in the temporal lobe, you may have very different phenomenology. You may have, oops, that was very brief. We may have automatisms like chewing here, and you may have impaired consciousness for a certain period. And if you have it in an area in the hypothalamus, you may have seizures which are characterized by, in fact, by laughter. So you can have very different types of seizures and behaviors with or without clouding of consciousness, with or without motor changes, and only with subjective symptoms, depending on the exact regions where a seizure is generated. When you look at focal onset seizures, you can also have an evolution of this semiology. So often you have subjective symptoms, sometimes called an aura, as the first phenomenon, and you can have objective signs like motor signs, clouding of consciousness, or elements, for example, like tachycardia, so vegetative symptoms. And later on, you can have a phase which we sometimes call generalization, although this may not be a correct term, where you have bilateral tonic and clonic phenomena. You may have post-ictal impairments, which overlast the duration of a seizure, which is mostly only in the range of 1 to 2 minutes by far. So these post-ictal impairments can last hours to days. And you can have pre-ictal symptoms, so-called prodromes, which may be interesting in the context of this Congress. So there are risks associated with seizures. So this is, for example, SUDEP, sudden death, occurring mostly in the post-ictal phase. You see here one recording from a patient who had a complete cessation of heart activity, and you see it depends on the group of patients that you look at. If they are pharmacoresistant, like surgical candidates, you have a very high risk of these phenomena. You have also a major social impact of epilepsy due to these seizures. So this is comparison of epilepsy, cerebral palsy, movement disorders, and degenerative brain disorders. In Germany, 2010, you see loss of working days, work incapability, invalidity, and mortality were highest here in the group of patients suffering from epilepsy. Coming back to these subjective seizure precedents, prodromes, this is something which has been reported for a long period of time. So this is from Dostoevsky, The Idiot, and you see one example of such a prodrome that he says, he felt very curious today in a condition similar to that which had preceded fits in earlier years. He remembered that he had been particularly absent-minded, couldn't discriminate between objects and persons unless he concentrated special attention on them. So cognitive changes prior to a seizure. Other patients report mood changes prior to a seizure. There is a question how reliable these reports are. So we tried to see if it is possible for patients to predict seizures based on these prodromes and did not find that. But there are other groups like Hout and al. Who showed that patients may predict better than by chance if seizures will occur, maybe not based on prodromes, but maybe on knowledge on different factors. So there may be things preceding seizures which may be interesting in the field of this Congress. Well, going to the pathophysiology of epilepsy, there is a note sketch from a sketch which showed different reasons from that. The old one was from Lennox, so this is an adaptation of this. You can have different levels at which you approach this, micro levels of channels, synaptic molecules, a mesoscale of small areas of the brain where you have cell death and reorganization of the brain, and you can have a macro point of view like we have it in the hospitals, where you look at reasons like tumors, traumata, infections, stroke, or other reasons underlying epilepsy. So if you have a gross classification of epilepsies, you can decide one group which is mostly genetic, which is often widespread or generalized in discharge, but not necessarily so. And we have other reasons which are structural, which I showed you some examples before. Genetic epilepsies are thought to be about 40% of those that we have during lifetime, mostly polygenic, and there are only very few forms which we really meet repetitively in our clinics where we have a monogenic form. And one example is here. You can have defects of certain channels or of synaptic molecules like the GABA receptor here, which then lead to generalized epilepsy with febrile seizures and is autosomal dominant, for example. On the other hand, you have the structural epilepsies, and you see that it's very unspecific. You can have a wide range of different reasons why you get epilepsy, so from all kinds of morphological and structural alterations that you can look at, and this all can be accompanied by seizures. So if you pose as the clinician the diagnosis of epilepsy, this is based on several basic things. It's mostly the history of seizures, so what the patient or his relatives or other people report to have happened. Then you look at EEG recordings where you find certain interictal findings, so-called spikes in the EEG, and in some cases you document really the ongoing seizure and seizure patterns if this is necessary. So I will go a little bit into detail on the EEG. So this is a typical EEG. You see there are certain electrodes positioned in a certain standard system, like here the 1020 system, or you can increase the number of electrodes in the so-called 1010 system to cover the brain from some distance. And you see this is a very gross coverage of the brain. And then you look for things which are biomarkers of epilepsy, that is, they reflect this excessive hypersynchronous discharges, and it is mostly the interictal spikes, it is high-frequency oscillations, and it is seizure patterns, and I will show you a few examples of this. So this is a very old picture from 1935, when the EEG had just been introduced in the diagnosis of epilepsy, and you see here that this was a so-called petit mal epilepsy at that time. So it's a type of generalized genetic epilepsy, we would now say. And you see from different patients at that time, they made just one recording channel. And you see that there is a great similarity that was observed here with these spike and wave discharges occurring in certain patterns. And there are some specificities among particular types of epilepsy. So in generalized epilepsies, you have bilateral changes like polyspikes or spikes, followed by slow waves, and they can have different preponderance, occipital or frontal, depending on the age and on the syndrome that you have. In focal epilepsies, you have only a few channels of the EEG involved in these discharges, like, for example, here, the right frontal or left frontal, and you see here that there is some propagation to the other side, which, however, doesn't mean that it is a bilateral epilepsy, but it is propagated activity if you look in some detail. You can have also epilepsy with multifocal spiking here, for example, in a child with Hibbs arrhythmia. And you can have dependence on this spiking on the state of vigilance, for example, typically in the Rolandic spikes in a particular type of epilepsy occurring in childhood, where you see most of the spiking only if the children are asleep in a non-REM sleep. You can have different patterns like polyspikes, but in general this doesn't contribute too much to the localization. And you have to distinguish these spikes from normal patterns like these 14% per second positive spike waves, which are normal variants. So as a doctor, you have also to know about spiky potentials without relation to epilepsy. So you see some examples here, and this is kind of a list. So you see have quite a number of potentials which formally are very similar to spikes, but which do not contribute to the diagnosis of epilepsy. And these are things which are difficult for algorithms to capture so far, so they can have false positives when trained on spiky potentials if they detect things, and this has to be put in context then. In generalized epilepsy, you have very stereotyped ictal patterns. So you have 3 per second spike waves in absence epilepsy, 2 to 3 per second sharp slow waves in atypical absences, polyspike waves in myoclonic seizures, and generalized beta and gamma activity during tonic seizures. And just to show you one of the examples, this is not in seizure in a child. You see these generalized discharges. It's very low volume, unfortunately. So it is given to say lift your arm, but it does not do so. So only later there is this. She has heard that she should lift her arm. So there is a delay in the response, or even an absence of response during these generalized discharges. And you have different types of these patterns. So this is, for example, a rhythmic beta pattern, which is generalized in atonic seizure in Lennox-Gastaut syndrome. In focal epilepsy, you have quite variability of ictal patterns, which makes it a lot more difficult to distinguish this. And these patterns have an evolution, and I will talk about this a little later in some more detail. So When we look in these patients a little more in detail, for example, when we look at the reasons for the underlying epilepsy, or if we want to do epilepsy surgery, then we look within lots of additional methods, which I will go through very briefly here. And in these pre-surgical evaluations, where most of the data that we analyze here, also in the context of our Congress, are from, the questions are, is there a regional origin of the epilepsy? Is it only one such epileptic focus, as we say? How extended is this region, and can it be surgically removed without impairments? And for this, we use a number of methods. We use imaging measures, for example, high-resolution MR scanning. We use high-definition EEG. We use functional imaging, for example, looking at the metabolism of the brain. And we use tests looking at the functions of brain, so neuropsychological test batteries. And depending on what kind of deficit you have in neuropsychology, you can have some idea about which brain region should be involved. So, for example, if you have these visual motor tasks and memory tasks, it could be related to the parietal lobe, and so on. If it's memory tasks, it could be related to the frontal or temporal lobe. So you get some ideas about which functions are not working well. You have nowadays high-density EEGs, where you can try to localize the origin of spiking activity. You have newer methods like combinations of EEG and functional MRI to evaluate networks of epilepsy, so not only directly the spike focus, but also interactions within the brain in a 3 or 4-dimensional space, for example, with EEG fMRI or MREG sequences as used here. In some patients, you need also to implant electrodes to get recordings from the subdural area, so electrodes placed on the surface of the brain, or to get information from deeper structures of the brain, so-called stereo-EEGs, where you put depth electrodes into structures which are not easily amenable by subdural recordings. So that could be, for example, the hippocampus, or it could be the amygdala, which do not have field potentials outside the structure, so that you need to place electrodes into that. You see here some of these electrodes. These are the typical grid, strip, or depth electrodes that are placed into certain areas, for example, the hippocampus, the subdural space, and these patients have then these connections to some recording systems. And just to show you an example, when you would use this, for example, this is a grid recording in a patient where you have seizure onset suspected in such a possible lesion, like a focal cortical dysplasia, and you want to know the relationship exactly to the motor cortex. You can then decide where is the seizure onset zone here marked in red, and you can look at functional characteristics. So you, for example, make a mapping, see where the hand area is, and then you decide which area can be taken out by the surgeon and where you can only, for example, make superior transections for treatment. There are a number of other indications where you prefer depth electrodes. So one example would here be multiple depth electrodes placed in a patient who had an encephalocele in the temporal lobe, so distinguish the origin between, for example, hippocampus, amygdala, and the cele region, and you see here it is coming from the cele and not from the hippocampus. You can also combine these field potential recordings with single unit recordings. So in some some centers this is done. I think mostly it was done in the beginning in Los Angeles, but now a number of other groups also use these recordings. So then you can look not only at field potentials, but also to the accompanying activities of individual neurons, for example, during seizure onset. So coming back to the ictal patterns. So if you look at the Surface-EEG, there are a number of patterns which can be very difficult to recognize. So for example, here's some rhythmic beta activity. If you look into intracranial recordings at the same time, you see it's a lot better, the resolution, and you also see a lot easier where it is exactly coming from. So for example, here from the fronto-basal region, it is then spreading to the dorsolateral convexity. And that is then the time when you can also see it in the Surface-EEG, when a certain area of this dorsolateral convexity is involved in the spread, and you see here this extended spread during a so-called secondary generalization. The interesting phase for us is the transition from the interictal to the ictal phase, and you see here an example how it typically occurs in the hippocampus. So this would be a hippocampal recording. This is subdural recordings in the temporal lobe, and you see here in the hippocampus that there is repetitive spiking ongoing, and then it changes to such a discharge which is very rapid, and this then can evolve further to other areas and become symptomatic when these patterns occur. So interictally, this degree of repetitiveness of spiking has quite some variability. So this would be interictal, but it looked very similar to what we saw before in the ictal phase. This is a seizure starting like that what you have seen here in the hippocampus. So you see here this repetitive spiking, then you see this high frequency pattern in the hippocampus. The patient is sleeping at this time. You see the spread to the temporal lobe, and there is so far no clinical signs at this time. And only when this spread occurs to some degree, you see a certain amount of clinics. So in this case, that the patient will wake up during the seizure. Oh no, in this case, it does not wake up, so it is a subclinical event. So you would even, despite this spread, not see anything in the patient. Okay. And the next patient, here the hippocampus is on here shown, and this is diverse recordings from different other brain areas. And here you see that you have a similar pattern in the hippocampus first, and it is spreading here to other areas. And in this case, it is accompanied by some clinical phenomena after a certain while. And I think you see already here, it is not so easy to distinguish from looking at the EEG if such a phenomenon will be clinical, like here. So you will have some automatisms occurring here, some vocalization, and now some motor automatisms coming up. It is not so easy to say from the EEG if this will be a clinical seizure or a subclinical event. Okay. So again, subclinical patterns seen here. They are mostly shorter and have less evolution in terms of spread, but as you saw, not necessarily it is easy to see. So here it is very limited to this channel. If you look at these subclinical events, they can be a lot more frequent than the real clinical event, which makes it difficult if you think about what you want to predict. Do you want to predict an electrographic pattern, or do you want to predict a seizure which is evolving from this in clinical terms? And I think there is an interesting poster on this question by Christian Donners, poster number 13 in the evening, showing that from the early information that you get from the first 3 to 10 seconds of a seizure, there is a correlation to what you will see if this will become a clinical or subclinical event, or what kind of seizure it will become. So part of this information is available in the first seconds. I want to just briefly mention there's also high-frequency oscillations nowadays regarded as associated with epileptic activities, so you can have them at different ranges of frequency. So the normal high-frequency oscillations in the range up to 200 hertz, and very high or fast ripples in the higher range, 200 to 500 seconds. So this gives additional information to the spiking that we have looked up so far. So for example, here you see a projection of a lesion, in this case a cortical dysplasia on the brain, and you see that most of the High-frequency oscillations, that is the violet ones, are outside the area where you see a lesion on the brain. So that is important for surgical resections. You have to include this area where the high-frequency oscillations are generated in the resection, and so they may give important information on the epileptogenicity of a certain brain area. You see here, depending on the degree of removal of this area showing this high-frequency oscillations, you get better or worse outcome. For example, in this patient, only a 75% decrease by seizure frequency because you left intact here an area which could not be removed because it was a motor area. And I think there have been very interesting recordings made in the group of Greg Worrell and others who have looked at more high-density recordings in grids to show that there are some phenomena preceding the seizure onset that we looked up so far in a micro scale if you increase the resolution. So that may be interesting also when you look at seizure prediction or early detection of seizures. I want to finish with talking about epilepsy treatments. So there are three basic groups of treatments. One is anti-epileptic drug treatment, one is epilepsy surgery, and one is brain stimulation. And I want to mention all the three of them, but I want to make a first remark. All the efficacy assessments on these kinds of treatments that we have nowadays are based on what patients or their relatives report on seizure frequency. And this is a major problem in epilepsy because video assessment has shown that this correlates very poorly with objective data. And I think there's a very good study from Melbourne here, and Mark will talk about this probably in the next talk, showing that if you look very carefully and if you have long-term implants also, you see that what patients report and what you get from your information, looking at the EEG and looking, for example, at audio recordings of seizures, does not correlate well. So this is a major problem in assessing seizures and will be a reason probably to advance with technologies, just also for the purpose of documenting seizures. So when we look at anti-epileptic drug treatment, it is a continuous prophylactic therapy to protect from upcoming seizures. So you have to take it every day a few times. It is systemically applied. There is mostly interference with synaptic transmitter release, transmitter reuptake, and postsynaptic efficacy. It is developed in models mostly of acute seizures. It is purely symptomatic. And you see some examples. You can reduce excitation when you interfere with excitatory synaptic transmission. And you see some of the drugs, for example, sodium channel blockers acting here, decreasing depolarization of the synaptic endpoints. You have some drugs like pregabalin, levetiracetam interfering with synaptic release. And you have some postsynaptic agents like felbamate, topiramate, and bromponil who affect the postsynaptic response to excitatory transmission. So this is one side. And then you have the other side that is increasing inhibition, so increasing the amount of GABA available here by reducing its degradation, by influencing its reuptake, and again postsynaptically with standard drugs like benzodiazepine and barbiturates acting at the GABA receptors. The efficacy of this drug treatment is not so bad. About 2/3 of epilepsy patients can be controlled. However, if you do not respond to the first drugs, the chances of becoming seizure-free rapidly decrease. So you have what we call pharmacoresistance to many drugs. In this case, epilepsy surgery is thought of so to take out the area of the brain which is causing epilepsy, and you see there's quite a variety of spectrum of types of intervention that is done by the neurosurgeons. It can be done very localized resections, like a lesionectomy in the parietal region. It can be an insular resection. It can be very extended resections like multiple lobes, particularly in children with certain types of focal cortical dysplasia. It can be just a resection of the hippocampus. It can be a disconnection of a whole hemisphere, or it can be just a callosotomy preventing spread from one side to the other. So if you have resective epilepsy surgery, you get a very good outcome. About 60 to 70% of patients become seizure-free, which is a lot better than with medical treatment. We have also now available a number of brain stimulation treatments, transcutaneous treatments, mostly activating areas of the brain stem, like the vagus nerve stimulator, for example, and transcutaneous vagus nerve stimulation. You have also trigeminal nerve stimulation available now. There is thalamic stimulation, which is working on widespread networks, particularly in the temporal and frontomesial regions. And you have a responsive focus stimulation available in the US to treat areas where exactly seizures originate from. When you look at the timing of this, you have some treatments which go more or less continuous, for example, thalamic stimulation or traditional VNS, so you have a stimulation every few minutes to have a more or less continuous effect. You have also treatments which are discontinuous, so you have mostly rely on your modulatory effect of stimulation. That is the case with transcutaneous stimulation procedures where you stimulate for a few hours per day. And then you have event-triggered interventions, for example, in the responsive stimulation. I will briefly go into this. There is a new method of cardiac-paced vagus nerve stimulation which has undergone a study, E36 study in Europe. So you see here the principle. You look at the heart frequency in many seizures, particularly temporal lobe seizures, go along with an increase in heart rate. You have an adaptive background activity here, and you see once a certain threshold is reached, then you will have a stimulation which is induced here in this vagus nerve stimulator in order to suppress seizures. So in this study, 6 out of 18 patients had such an increase defined as tachycardia, which was a heart frequency about more than 100 per minute, and an increase by 30 beats per minute. And this was 15 out of 85 of their seizures. And you see one example from our patients. So this is the threshold crossings that were here. You see here the seizure events. So what you see, it was possible to reach a sensitivity of 80% in this study in a major subgroup, but you see that there is quite a high number of false stimulations if you apply this, so the specificity is very low. And this is the rates of false stimulations with the settings that were chosen here. It's in the range of 4 to 6 per hour. And you see that you have a few seizures, maybe 1 or 2 per day. So you have mostly false stimulations with this technique. And this is the RNS system, which is based on detection of intracranial seizure patterns in the area where seizures come from. This is from NeuroPace publications. So you try to detect a seizure pattern and then you stimulate in order to suppress it, shown here. This has been evaluated also in terms of efficacy, and it has shown a significant reduction in the number of seizures occurring, but again, the specificity of these detections was not very high. So it was, there were some patients who had several hundreds of stimulations per day, whereas the normal seizure frequency in these patients may be in the range of 1 to 5 per day. So there's a debate on if seizure detection is really a solved problem. Some people say yes, so they have no false positives, no false negatives, like for example published by this group, and other groups do not find this again. So for example, applying the same algorithms on different data, for example from the Freiburg data group, you see different performances like Boutonniers has shown in his thesis in 2012, which is also published now. So to sum up, epilepsy is a very common neurological disease, which is the second most common after migraine, in fact, of the brain. It is characterized by irregular occurrence of functional brain disturbance called seizures. We have treatments mostly working on a continuous basis like pharmacotherapy or stimulation. We can resect the areas, And overall, we are successful in about 70% of our patients. Only recently have brain state-dependent interventions been introduced, and we will hear a talk on this right now from Mark Cook. And I think so far the detection procedures that are implemented in clinically available devices have problems with their specificity, either if that's based on ECG or intracranial EEG. And I think it will be a very important task during this meeting to look up how much we can learn about pre-ictal phenomena and to include this in such closed-loop treatment devices and to see if we come to a progress in this field. Thank you very much for your attention. I don't know, is there is questions? Yes, please.
Andreas, on the responsive stimulation for the vagus nerve stimulation device, do you have a sense if stimulating on a seizure shortens the length of seizures, or what kind of data do we have for that, or what is the impact of that? What's the advantage of stimulating on the seizure itself? I know patients often tell me they use their magnet. I've never really known whether to make much of that or not.
Yeah, it's a very good point. So I think we don't know. So we know that patients sometimes believe that they can control their seizures if they activate the seizures. It has never been shown convincingly, in my view. In this study, there was no efficacy assessment, and the stimulation was done at an intensity which is not really effective in most of the cases in the interictal phase. So I don't know if you can draw conclusions. So they looked at 2 points in this respect in the study. So they looked at the duration of seizures during the study and during earlier phases of video EEG when this vagus nerve stimulator was not on, and the mean duration was shorter in this study. But the problem is that the conditions were not similar. So in the earlier condition, the medication had been reduced, and here it was not reduced. And the second is they looked at the duration depending on when the onset of stimulation was in those seizures where stimulation started during the seizure, and they found that when the earlier stimulation occurred, then the seizures tended to be less long. So this is, I think, the only hint that we have that it may be effective, but there is animal experimental evidence that VNS is not effective during a seizure. So I think it is an open question which has to be solved by the company. Brian.
Andreas, I really enjoyed hearing you as always. I just had a question to step back with your experience in these areas of neurostimulation. If you had $100 million or $10 million, I mean some significant amount to invest to try to improve the efficacy of neurostimulation, who would you put it? Would you put it into basic models? Would you put it into platforms? Would you put it into more clinical trials? I'm kind of wondering, the clinical devices kind of got out ahead of us a little bit, but I'm just curious where you would put your money.
Yeah, that's a very good question. Unfortunately, I don't have the money anyway, so it's very hypothetical. He could give it to me. Okay, so I think it depends. So we have the problem in the human that we can test only very limited types of stimulation. So in principle, of course, it would be nice to have animal models to test these interventions. But in reality, I think we have only the hippocampal model of epilepsy, which is working well in animal models. So to find the best stimulation paradigms in the hippocampal stimulation, I think it is worthwhile looking at animal models and trying to invest into that, for example, to look at multi-site stimulation techniques and so on. On the other hand, we have most of our epilepsies in the human from other reasons than hippocampal sclerosis. It has become, at least in Germany, almost eradicated, and we live mostly on foreign patients to find somebody with a hippocampal sclerosis nowadays. So most of our patients have malformations of cortical development, and I think there are no good animal models of this, or at least They are very complicated and only few people have them. So I think we have no choice to also go into human studies and to offer this to a number of patients who have these cortical dysplasias, for example, which are particularly pharmacoresistant, and to see how we can intervene with different strategies. And I think as we have to join our efforts here, it would be very important to have a multinational and multi-site strategies here, because it is, of course, necessary to have a sufficient patient number and to test certain paradigms, and it is very difficult to do that in a few centers, even if Greg has the money. I mean, he has a very big center. Maybe all the patients would come to him, but you probably need an international collaboration to go forward with that.
You've ever been there in February?
The different anti-epileptic drugs, or is there any identification of how different anti-epileptic drugs affect these parameters or these seizure characteristics?
Not really. So, I mean, there are some ideas from basic studies, mostly that most of the drugs more affect spread of epileptic activity than just the generation of seizures. But there is relatively few studies really looking into some details. So it is practically not done. It's a very good question. So you could look at the individual drugs which are taken out during pre-surgical monitoring and see how that affects the seizure spread. And certainly we know that, for example, secondary generalization more occurs if you withdraw these drugs. But this is not really being analyzed so far as I know, on a systematic level, depending on the mechanism of the drug.
Any other questions? Yes, Rebecca.
Thank you for your history discussion. My question is how to define the pre-ictal stage. Every time we talk about the definition of pre-ictal stage, we really confused. Should we depend on the symptoms or the EEG discharge? We cannot find any specific symptoms before the real ictal stage. Only few patients describe their unspecific feeling like they're tired or sometimes confused, but most patients cannot describe exact symptoms. And also about EEG, we cannot find specific pattern related to what. So how can we define the critical stage?
I think probably Mark Cook will give the answer, but my answer to your question is, it is first a very good question, because we really don't know if there is a specific pre-ictal phase in my view. So what we have found from all the seizure prediction methods that I'm aware of was mostly that you saw some periods with a higher risk for seizures, which I would tend to say you have some pro-ictal phases, which can be very extended, and we have no real knowledge about some phenomena really directly leading to a seizure, so that we have a change in our dynamics that we can clearly trace from a certain stage, which is proceeding to a seizure, which would, in my view, say that this is a real clearly pre-ictal phenomenon. But maybe we have a talk on these states right now, and I think it's the perfect way to give this to the next speaker who has maybe different ideas.
Well, thank you for that segue there.
So we now have a tag team of speakers, Mark Cook and Pippa Caroli, who will be talking about brain activity and seizure statistics in epilepsy.
I think it's a split screen, so if you can start there. Start the presentation. And then Okay.
How do you click to the slide?